Let's get oral. Let's get oral.
Howdy, howdy. Welcome back, listeners, to Let's Get Oral. I am Jonathan, one of your lovely co-hosts here on the LGO team. I got Camille here once again as a co-pilot. How you doing, Camille?
Hello, hello. Can you hear me?
Yep, sounding great as always.
Excellent, because I just messed with my settings, so
Classic. But today we are excited to have another special guest join us on the podcast. We are featured to be sitting with Dr. Sarah Balaster. She is a board-certified periodontist who's multifaceted into technologies, both when it comes to lasers and doing some personalized health with her patients in her private practice today. Welcome to the show, Sarah.
Oh, thank you so much for having me. I'm so excited to sit with you guys.
I know before we were able to connect, we had a little bit of a back and forth. And as I was going through just your credentials and experience, hella impressed. I love seeing people and clinicians who, it's one thing to market yourself, but it's another thing to really focus on those interactions we have with your patients and keeping themselves and also your peers up to date with the technologies that are available for improving their quality of life in the mouth and beyond. So I love being able to connect with people like you and hear a bit about your journey leading up to where you're today. So one of my usually common questions we have for practitioners such as yourself is, what inspired you to pursue such a career? And also, were there any specific moments in that journey that really solidified you on this path?
I have an unconventional story, as I'm sure many people do. I wasn't sitting at home going, like 5 years old, I want to be a dentist when I grow up. I'm going to take this normal path and I want to be a periodontist. I was actually a fine arts major. My whole family's in the film industry. I am the black sheep daughter of a prop master from New York. I went to Wesleyan University in Connecticut, where I fell in love with Connecticut. It's where I practice now. But I was totally a fine arts major. So picture this. I graduated fine arts school. I'm trying to find myself as a young artist, what I'm doing in my life. And I'm working at Pearl Paint, Route 17 in Paramus. Anyone who's familiar with New Jersey will know this icon. And I'm framing artwork. In walks Dr. Dana Cassandra, who did not know that she was a dentist or anything at the time, comes in to get some art framed for her dental office and her dental diploma. And we just hit it off and connected immediately. I just was really inspired by how she saw dentistry as art, who she was as a person. We just vibed, hands down. And she offered me a job in her practice. And that was my first exposure to dentistry, watching her and how she worked, and she morphed into this amazing mentor for me. What inspired me to go back to school, finish my pre-dental credentials, take the DAT, go to dental school, become a dentist. She hooded me when I graduated. And then I became a periodontist and worked in her practice, like total full circle.
Wow.
It was like if that moment didn't happen, like we would not be talking right now.
That's wild.
So thanks for letting me share that story. I just really shout out. She practices in Paramus, is an amazing mentor and a cosmetic dentist.
Amazing. I'm very interested. Are you doing any art now?
I really, in the sense of like printmaking or photography or drawing, not so much visual art, but I look at what we do and I think being able to step back. And there's so many people who are creative. Everything we do is creation. Yeah. And every time we partner with someone, it's co-creation. When we work with our patients to create a smile, it's not my vision. We're co-creating something beautiful and meaningful. This is art. What we're doing right now, we're creating like that audio visual experience. So I carry it with me everywhere.
I agree.
Mm-hmm. I feel like dentistry is definitely unique when it comes to its intersection of arts, cosmetic, aesthetics, and health and wellness. I love hearing that outside of that realm, how much it still fueled your journey in many ways. It's not the same, but I can feel some common threads or vibrations from that myself from the microbiology perspective, because I spent so much time looking in a microscope, right? And particularly in a dark room doing fluorescence work, and being a child of a NASA community, I also spent a lot of time looking up at stars. So it was just never lost upon me when I was looking at various biofilms and trying to tag specific bugs and whatnot. These clusters and globs and things I'd seen in the darkroom always to me just looked like Hubble telescope images.
That's pretty cool.
That's super beautiful.
Yeah, and just like the juxtaposition of literally the micro and the cosmo on scale. And so like to this day, you can't see it now, but above me I have some canvas prints from my PhD work of different mixed species biofilms gathered from plaque that's specifically tagging like Candida, various versus strep versus Vionella, and other bugs with different colors. And if you didn't know any better, to me, it just looks like a deep space collection of images. But I tell people, I'm like, no, that's my mouth.
Like yours specifically. Yeah, that's like a whole nother level of meta that like.
So again, I think we're all artists in some way, shape, or form. So I love hearing such stories.
I agreed. I love all of this. I'm deeply creative myself, and I always kind of try to dig into whatever the creative aspect of whatever job I'm working in the moment. I am always inspired by other people's stories. I wanted to follow up on your journey in oral health and dentistry. So you had a non-conventional undergrad for sure. Didn't exactly line you up, but you made that work anyway. But then going through dental school, I know that most of these programs are very traditional, and yet you lead a slightly untraditional practice. And by that, I mean like you're using Supermouth as your primary product line. And so it's slightly unusual to find somebody that is kind of moving outside the typical predictable path. How did you get into that part of your journey?
So I'm going to unpack that question a little bit. So dentistry and my education was extremely conservative, and I'm sure it's a lot different now. I remember UMDNJ is now Rutgers, University of Medicine and Dentistry of New Jersey, and we wore uniforms, and you had to wear white socks and white shoes and no nail polish, and they'd kick you off the floor if you were unshaven. And it's just this really conservative, this is how it's done, this is how it's always done. No, like, foundations of biology, got to know your history. And as an art major, had to learn anatomy, had to learn figure drawing before you break outside the box. So I think having like constraints and having that structure allows you to build upon and then break free and disrupt from systems where you see they're not serving. So yes, I have a unique perspective where I can go 10,000 feet and look and say, well, why are we doing osseous surgery for our patients, right? Yes, that was the correct thing to do in the 1950s or 60s, 70s, when that was the option we had. But it's like, what's the goal of the surgical procedure? It's to eliminate infection, whatever, get the mouth stable. Like, what are the actual goals of it? And then do we have more modern tools where we can achieve the exact same goals rather than just saying, oh, we do it this way because that's how it was always done? And I hope that answers your question in that
Definitely.
sense.
I appreciate the kind of understanding the classic where we've come from to build into a future that is more meaningful and more appropriate as we learn more. And I think that that's a message that we could just reiterate over and over and over, because I think as any consumer and patient, we like to think that, our providers know the health space that they're working in. And I have to remind myself and others all the time that science is not a fixed space. It is constantly evolving, and we're constantly moving the needle. And so, cardiovascular surgery, for example, is blowing my mind right now. Like the amazing things that they do there are just incredibly different than just say 20 years ago. So again, dentistry similarly has these kind of old pedestals it's sitting on, but there's so much opportunity here. So I'm happy to see somebody who's taking those pieces and moving it forward.
Yeah, and when we dig back deeper, so first of all, the silos of dentists, physicians, podiatrists, like we got to dig back and get out of these silos and really look at our shared foundation and break free from that and join together and learn from each other. I had the opportunity to present at a rheumatology conference. Yes. The overlap in what we're doing and this is not about dry mouth, but the regeneration we're doing in perio when we're using lasers to regenerate, not repair, like regrow the PDL, regrow cementum, inserting Sharpie's fibers, and what we can do with lasers there. And then speaking to rheumatologists and saying, how does this translate to regenerate joints? Like instead of cutting and replacing, doing full joint replacement, how can we repair and translate and share our knowledge to, go forward and better people as a whole? Like we shouldn't be advancing like one way here, one way here. We can evolve together.
Oh my gosh, how was that received?
Incredible. First of all, I was more nervous than I've ever been. I've stood in front of audiences of 2,000 people and I'll jump up and down and, I am not shy. But that room in front of 25 heads of rheumatology, these are like the leaders of a group of a few thousand, like my heart was pounding. I felt like I was a kid. I'm like, I'm so nervous.
That is so great. I love
like
that.
And as soon as I kind of just like let that elephant out of the room, like it just took the air out of it. And we all realized we're all here to help patients and we're all here to learn. So, there's nothing to be separate about.
So I kind of want a whole other episode with you on laser dentistry and the opportunities there, because there's so much happening in that space that, deserves a lot of talking and digging in, because I think that it's an opportunity space that's underutilized. But to focus in on the dry mouth, what got you started in that specialty? What were you noticing in-house that perked your interest?
I'm going to just rewind a teeny bit. So everyone approaches patient care a little bit differently. And you were mentioning that. So, we all learn the foundations and then we kind of find our niche and how we like to practice. So when I have a consult with a patient, or I'm even sharing with friends or other, colleagues or groups, it's like, you got to find someone that works for you, that you like how they practice. I'm not for everyone, but if you match with me and I vibe together, it's great. I like, meeting my patients where they are and looking at the whole patient. And I think about, just because something's like physically possible from an academic standpoint doesn't mean it's the right thing for our patient.
Right.
Like just because I can do orthodontics and take out this tooth and do ridge augmentation and use ocular mesh and do all these crazy surgeries doesn't mean, like, to get this perfect outcome doesn't mean getting 90% of the way there with something that's way less invasive, way less expensive, will make that person happy, isn't also a viable option for them, if that
Absolutely.
makes sense. And then dry mouth. So when we approach care that way as this thing, like I have patients who call and we all do this. It's like, how much is an implant? I want an implant. I want an all on X. I want this. I'm like, you don't want a full arch. Like you want to be able to eat, speak, smile, chew, and be comfortable. Like you don't want the thing. Like, what do you really want? The analogy I always give, it's like, do you want your partner to buy you flowers or do you want to feel loved? Like, what is the core of what you're trying to achieve? And then let's partner together and get there. So this is a long-winded way of saying, when working with patients who have had extensive caries, most likely because they had, dry mouth, and they're coming in for their full arch reconstruction, which we do in practice from implants to restoration for patients. When we get their teeth out, we get them in a well-supported, healthy prosthesis, and it's like, I still don't feel good. And it's like, why do they still not feel good? Their mouth is dry. Their tissues are rubbing together. Like they're not comfortable. We didn't look at the whole picture of like, then let's dial it back. And this is what practice is. It's the practice of dentistry. No one's perfect right away. It's like, oh, you got caries to this point because you had dry mouth. That's the root cause. Then when we put a bulky prosthesis in your mouth, you're not having the lubricity that you want. You're not maintaining a balanced oral microbiome. So then you're getting peri-implantitis around your implants. You're getting oral sores because you're rubbing on your all-on-X prosthesis. So that's a very long-winded way of saying, years of experience in connecting and listening to our patients and trying to get to the core is what led to this desire to address dry mouth.
So when you're doing a patient assessment, you mentioned kind of treating the whole person. So I wonder about things like, how are you assessing the whole person, relating to systemic and dry mouth factors? How do you kind of get clued in? Obviously, caries would be a big indicator for dry mouth, but just holistically, where do you kind of approach the person and then dial it in for something like dry mouth?
Yeah. So first of all, we have to listen. And I know that sounds like a very small thing, but it takes an immense amount of effort to be absolutely present in your time with your patient. They're the most important person in that moment. And you have to listen to what they really want and then play detective. So overall, there's an increase in prevalence of dry mouth recently. So some of the biggest causes of dry mouth are CPAP, polypharmacy. Like 33 million Americans take at least one medication. And then another like 34 million use sleep apnea devices or more. These are just ballpark estimates. We can, look up and cite these. But, when you're looking at a patient, there should be certain things that clue you in to some of their needs as detective. So you see 3 or more medications, red flag should go up. This person is at risk for dry mouth. You see lifestyle choices like alcohol or marijuana use. Now that it's legal in a lot of places, our patients are using it. And I know it may make some providers uncomfortable, but we have to talk about it because it's impacting our patients. So you need to ask, you need to be comfortable having personal conversations and digging into these root causes. It's not just Sjogren's syndrome, huge cause of dry mouth, by the way. It's not just radiation to the head and neck. These are just the big ones they teach you in school and I'm sure you've taken multiple choice exams in your life. And then you're just like, you stop reading the questions. You go, oh, Sjogren's dry mouth. Like you don't even finish. Yes. You're like, oh, Zika symptoms, this. It's like the patient, Jane came home and reheated her white rice. You don't even need to, you know exactly what I'm talking about. You don't even need to read the test questions to know what they're talking about. This is like very deep nerding out right now. I got off track. Reel me in.
Okay. So medications, CPAPs, sleep apnea. Do you collaborate with an airway specialist just to kind of address those issues or at least get them into awareness?
So I personally don't do sleep dentistry in my practice. That's something I would refer out. And you don't need to do that in order to support someone who has a CPAP. Just knowing that 40% of patients who use a CPAP experience dry mouth is enough to be able to partner with. So just ask the question and then ask, is your mouth dry when you use the CPAP? Do you like using the water vapor tank? Things like that. We can support our patients without having to be, super deep or specialist. Like you can treat periodontal disease without being a periodontist in your practice. That's one of the beauties of dentistry. And I think we not to criticize the question at all, but I think we let things like that get in our way as a barrier for providers. And you got to do the best you can with what you have and just connect and be a person and ask these questions and listen. And you'll do, as much or more good as someone who's doing that in their practice. That's an expert in that field, if that makes sense. Don't be shy. Just like talk about it. You can help people.
Do you think that your patients who have dry mouth, are they all aware of it? Is that something that they
Yeah,
know?
that was going to be my question.
No, it takes a 60% reduction in salivary flow before a patient can notice it, which is why you've got to ask probing questions.
I'm sorry, you 60% till they notice, but what percentage drop would you start to see pathology?
Oh, that one I have to dig into the literature for. And it also depends because there's different types of saliva in our mouth. We've got serous saliva coming from the parotid glands, and then we've got more mucus saliva coming from our lower glands. And it's not always about quantity, it can be about the quality. Because if it's too thick, then it's really ropey and it's not moving. If there's too much fluid, you're not going to get all those like yummy IgAs, that like yummy lactoferrin, hydroperoxides, like all that stuff you're missing because that's coming from like the thicker. So you really need a combo. One more thing that's a barrier for providers is like, oh my God, one more thing I have to do in my practice. Oh my God, I have no chair time. Like, when am I going to look for dry mouth? When am I going to screen for this? Take a breath. Use your eyes, instrument number 1 and number 2. When you do your oral cancer screening, take a look. Do you see cracked dry lips? Do you see angular cheilitis? You're already looking and doing an oral cancer screening on every single patient. Do multitask, Are you seeing white? Are you seeing, candidiasis? Can take up a 2x2, wipe it off, because we should make sure that's not a white lesion. If it's wiping off, we're having, thrush, we're having yeast infection. This is sign for dry mouth. Are you seeing cervical decay, especially in the maxillary posterior region, right? Where you should have a high serous flow because you're getting buildup and decay there. So there's just little things that should be, ways of screening that you're already doing without consuming additional chair time. Does your mirror stick to the patient's cheek while you're, retracting or working? Are you seeing salivary pooling in the floor of the mouth? I'm just listing some things that should red flag that can, make you have these conversations. But I want to get into the questions, which is not just, does your mouth feel dry? Are you having trouble eating, speaking, swallowing? Mm-hmm. Can you sit down and eat a plate of crackers without water?
The saltine challenge.
They call it the cracker test. Apparently it's like a thing in rheumatology. And I was like, okay, you guys must do like scintigraphy and salography and like all this stuff. And they're like, no. We just asked them if they can eat a plate of crackers. And I was like, stop.
How's your charcuterie board skills when it comes to eating, Ellie?
Yeah. So it takes you got to dig in, and you really have to, help people put that puzzle together. We're detectives. Diagnosis is, you get to play detective. It's fun.
Do you see a space for salivary diagnostic here?
Yes. So, there's definitely a space for salivary diagnostics. It's huge, up and coming, really easy to collect. One test that I use in practice that a lot of providers really like are using Fishburne tabs. So when I speak about Sjogren's syndrome, there are SICA symptoms, which is like dry eye and dry mouth. They're these little tabs that people use the Schirmer test to collect tears that just wicks to see how wet your eye is. Fishburne tabs do that for your mouth. It's like you bite on a piece of paper for a minute and it wicks and it gives you a score. So you can track a patient's saliva over time. So you could have a patient and they're at a 3. And if you just mark that, and if this is something you like you don't have to put this in your practice, you can just, look and screen other ways. But if you want something that's an additional procedure, or you want to do something, more concrete or billable in your practice, you can do this and then track how people change over time in their charts, which is looking at their whole body. We see how their medications change. We look how their x-rays change. Why are we not looking at how their saliva's changing?
I do feel like those tools
time
are really nice to have when you're trying to convince your patient to act on an issue, because then you can point to parameters that have improved or degraded in this really clear path that allows them to see that it's not just you trying to, get some more money from them, without.
It's so sad that that's part of, our system.
I know. And it's just, I mean, I think we're all skeptics now, and just trying to make sure we're doing our due diligence all the time. So it's a tough, I think you could probably add a specialty onto how to give a consultation. There's an art to it. There's a psychology to it. There's a bedside manner to it, but yeah. So once you have a patient that is struggling with dry mouth, what are some of the things that you talk about to improve or treat with?
Right. So first of all, dry mouth or xerostomia, let's use the big fancy word, is a subjective feeling of oral dryness or an objective decrease in salivary flow. It is not a disease in itself. It's a symptom. So you got to figure out what's causing it. If you see a patient with severe dry mouth, look at their eyes. If they have dry mouth and dry eye, get them to a rheumatologist because there's something else going on. If they have dry mouth as a result of radiation to the head or neck, or they're already under treatment with a rheumatologist, you can ask if they're taking systemic salivary stimulants, right? And we can have conversations that way. But the thing I want to drive home is if you see dry mouth, dry eye, get them to get their eyes checked, because dry mouth's uncomfortable and leads to sores. Dry eye can lead to blindness, and we don't want that for anyone. We're already looking. Look at the whole patient, at least from here up in the chair, please. So what do we offer to patients? We have to, meet them where they are. It's a spectrum, right? Some people might have dry mouth when they're, had been drinking alcohol or using recreational marijuana, or they just introduced a, antidepressant or something into their, lifestyle. The smallest thing you can do is just hydrate. So drink more water. That's step one, right? And then if drinking more water doesn't work, we can introduce water-based treatments like over the counter. I think the most common one that comes to everyone's mind is like, Biotine, right? So something similar, a water-based rinse would be step one. If that's not enough, there hasn't been an option in the space. Enter, lipid-based sprays. So enter a Coral. A Coral dry mouth spray was put out by 3M a few years ago, was pulled from the market because it didn't have high margins. Many pharmaceuticals, doesn't mean they don't work well, doesn't mean there isn't a need for them. It just means it wasn't successful. So they got picked up by K Pharmaceuticals, who, nurses fledgling products and gives them the attention they deserve. So it's back on market in full swing, and it is the only lipid-based oral spray. So before, it just used to be drink more water, do water-based. Now you're on, pilocarpine. Like there wasn't an in-between. And I'm so grateful there is. I do, full disclosure, I do work with K Pharmaceuticals to help consult and promote this product, because personally I use it in my practice and I see such a need for. You shouldn't go from like mouth rinse at the drugstore to like taking a systemic medication. Like we got to have some options in there, and having a lipid-based spray that traps the existing saliva in and can last while you're eating and doesn't get washed away is a great option. So the scale goes from drink more water, water-based treatments, lipid-based treatments, prescription salivary stimulants, and then any combination of the four that works for your patients, because no one is we're not robots. You gotta find, even like pilocarpine's gonna go up and down with its stimulation, and you might need lipid-based spray in between. You might want oral-based spray in between.
Do you ever recommend or think, quote unquote, supplements such as like chewing gums or lozenges or things that could mechanically potentially stimulate salivary production? Is that ever an option for any of your patients?
100%. So if you look at like the difference in flow rates between, stimulated and unstimulated salivary flow, if you're low and then you stimulate, you're going to bring up. It comes with risks. Sugar alcohols So even if you're using sugar-free and you're doing sugar alcohols and you consume too many sugar alcohols, we're going to have some side effects, especially some GI and diuretic implications of using that. So it can help. If you're using things that are acidic, you're going to change the pH of your mouth. If you're putting sugar in your mouth to have candies, you're going to change the pH of your mouth and then increase your risk for caries, which you're already
A problem.
at risk for. I mean, we can talk about like mouth pH if you guys like really want to.
Always.
I think we're building to a spit series that I've been dying to have. So yes, we can definitely chat about that.
But like, right. So there's different aspects to xerostomia.
Mhm.
So there's the comfort
Yes.
and the physicality of it. So we talked to speech language pathologists who have been incorporating this Acoro lipid-based spray into their protocols to help with the lubricity and speaking and swallowing in patients who are recovering from head and neck cancer, right? You got to get through it. You got to live, right? Step number 1 is like be alive. Then step number 2 is quality of life. And a lot of dry mouth is quality of life for patients. So there's that aspect. Then there's the aspect of what are the associated risks, like increased caries. So if you're using a lipid-based dry mouth spray, great. pH is 7, wonderful. You're getting a coating in your mouth. You're trapping in the little existing saliva that you have. But you also need to be using something to manage your caries. Whether we're using, fluoride trays, fluoride treatments. You mentioned Supermouth. I love their line of sodium lauryl sulfate-free fluoride products and, brushing with it. The unsolicited advice I give every single person I meet is if you're using a fluoride product, don't wash your mouth out after.
Seriously.
Mind blown.
Yeah.
Mind blown. Like, we watch on TV and they go, brush, 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 and then they rinse with water and they spit. And I'm like, would you literally buy eye cream, put it on your eyes, we take care of our skin, and then wash your face?
Yeah.
For somebody who doesn't enjoy mint all that much, I will rinse it out just because I don't want the burning to stay.
Camille, we got you. They've got chocolate, vanilla, strawberry, and mint. And my 6-year-old blends them together on her toothbrush because she wants a Neapolitan flavor. Is that how you pronounce it?
That's so great. I love that. I'm going to introduce that to my daughter. I make a toothpaste, and so that's what I use. But she likes their flavors, and she's primarily using the vanilla, but yeah, or strawberry.
Yeah,
Neapolitan. I love that.
I've tried to get her to use the mint. She's like, spicy. Spicy. The same thing with seltzer water too. And as you know, someone who lives in New York, like everywhere is all the water's carbonated, like soda water is so popular, and it's like spicy. I'm like, I don't know if that's the right.
Yeah, exactly. But I can understand why somebody would want to rinse that out. But just having other flavors. Right. I wanted to bring up one of my friends works in Big Ag, and she just happened to fall across this paper. I can't remember exactly when it came out, a few years ago. I call it the cow spit paper. But the implication, I'll send it to you. It's really cute. It's basically a study, grain-fed versus grass-fed, and the amount of chewing and the amount of saliva. The healthier fat deposition on the grass-fed was attributed to the saliva flow.
You have to send that to me. That is
so. They
really
did
cool.
make an inference on human hygiene and how it might be an implication for the benefits of chewing and swallowing with an abundance of saliva, and kind of poo-pooing the grain just because it's so easy to swallow and they don't have to chew as much. But I think that we already know from all of our human studies that chewing is a very important aspect of nutrition. And I don't know that we've really uncovered the saliva aspect, but we know that that's the first part of the food degradation pathway. And so I could see how just having a reduction in salivary flow might set you up for a whole host of digestive issues, for example, and then a fat deposition that is maybe less desirable. So I think that that's also kind
Yeah.
of an intriguing pathway of science that we're looking at.
I would think thank you for sharing. That's incredibly interesting. I want to carry it over to the chronic care population. So looking at our aging population, first of all, polypharmacy, many of these patients have laundry lists of medication, then the dry mouth associated with that. Then many of them have dentures or partials that are tissue supported. So those are not getting, aren't being supported on healthy, moist tissue. So they're not getting retention. So they can't eat well with that. Reduced salivary flow, you're not having your enzymes. You don't have your EGF that's protecting your epithelial lining. So you're getting mouth sores. Never mind the level of care that some of these facilities have around oral health care. Like many of these patients aren't seeing dentists. No one's helping them brush their teeth. And it just has so many implications, both physically, then mentally, the isolation of not wanting to eat in front of someone else. Then you start losing social interactions. If you are a fall risk and you have dry mouth and you're waking up at night to drink water, then you have to pee more, then you're getting up more, then you're increased fall risk. It's not just, this is what I mean when I say the whole patient. It's not just like, oh, let me check your med history. Let me look at your teeth. No, like, what's your lifestyle? What's important to you? Do you have a vegetarian diet? Like, I have to have these conversations when I'm doing full mouth restoration with patients. Like, what's your lifestyle like? Is this going to meet those needs? How can we support you? You don't want grandma to fall and break her hip and then end up in a hospital with, you can get pneumonia when you're in the hospital. Why? Because her mouth was dry and she had to drink water and then she fell. We could have stopped this.
Yeah.
I'll pause because I could just go off the deep end on that one. Take a breath.
I agree. I mean, especially long-term care, I know that they have these little sponges and they just drench it with chlorhexidine, and that's kind of the hygiene of the week, and then the diet is mostly like minestrone soup,
Soft.
Yeah.
Yeah. Really, really soft.
Exactly. Yeah. I don't know how to improve nutrition or like factors of chewing, especially for, the long-term care facilities, for example. That's just such a hurdle. I think there's so many things to address there, but holistically, what things would you avoid for dry mouth or try to convince your patients to minimize?
It's going to, well, first of all, don't ever say a problem's too big, we can't impact change, ever. And I want to make sure that our listeners know that anything they do and any awareness they raise is going to make change. So us just talking about this and people listening and understanding that there are options, such as something as simple as a spray for a patient, could change and impact someone's life. A colleague of mine, whenever I get overwhelmed with things and I kind of just like shut down, like this problem is too big, he always says, you eat an elephant one bite at a time. So take a bite. I'm not encouraging eating exotic animals by any means, but now let's go over to what I tell my patients with dry mouth to use. I'll get off my soapbox. It's a lot of lifestyle things. So, alcohol is going to dry out your mouth. Using alcohol mouth rinses is also going to dry out the tissue. So, you really want to make sure that, while, Listerine, alcohol, and I'm not picking on them by any means at all. It's one that people really, really know. You want to look at what ingredients are making change. So getting something with essential oils that are going to have antimicrobial effects, something that doesn't have alcohol in it, that's going to make you feel fresh and nice, something that has stannous fluoride in it, which is going to impact the oral microbiome at all. You want to look for those active ingredients. It doesn't have to burn to be working. It doesn't have to be spicy. Go back to
Exactly.
spicy.
Mhm.
It doesn't have to be spicy to be working. So like fluoride mouth rinses are really great. Alcohol mouth rinses, no. Like if you're drinking a lot of alcohol, make sure you're staying hydrated. If you're doing lifestyle choices such as using marijuana, you want to make sure, and I saw some changes anecdotally in some patients who are using gummies to sleep, brushing their teeth, then eating the gummy, then getting caries, because yes, you're taking it like quote unquote as a medicine. Yeah. But you're then coating your teeth with like sugar, and then you're consuming something that's going to lower your salivary flow. And then you're going to sleep, and your resting salivary rate is going to drop in your sleep, and you're going to have an increased risk in caries. So it's a lot about order of operations. Same as if you're using multiple dry mouth treatments for a patient. If you're using water-based and lipid-based, water-based first, then lipid-based on top to trap it. Otherwise, you're putting on a raincoat and jumping in the showers.
Right, of course.
Yeah.
We
Trying to think of any other good lifestyle changes for someone. I think those are the biggest tip.
We didn't get into the microbiology of this. So I'm going to go ahead and break that open with, do you do salivary testing to kind of help that communication with your patients?
So personally, I'm not doing salivary testing in practice for my patients. So I look at it more, I take the more 10,000 foot approach in my treatment of periodontal disease. And we can talk about this when we discuss lasers, and it's just a type of practice. So there's lots of ways to treat periodontal disease with, topical antibiotics. If we look at things like Arrestin, we can look at things like people using hydrogen peroxide. But if you're not targeting a specific pathogen and you're looking holistically, so for example, using lasers to kill bacteria, you're able to ablate anything that that light is attracted to with that chromophore, right? So we say dark pigmented bacteria, but we also destroy yeast, which is white, because it's the chromophore, not the actual color of how when you don't need to do blood agar, and we're looking at dark pigmented periodontal pathogens. So I personally don't do salivary testing, but I think of it more like holistically, like the community. When you have the dry mouth and the pH is shifting, you're going to get more gram-negative anaerobes. Same with when you get deeper pockets in periodontal disease, you're creating an environment where that can thrive. So balancing out and just creating an environment where we have the balance tipped towards the positive, right, is the way that I personally approach. Yes, have I done salivary testing when we get stuck on a refractory case? Possibly, but it's not something I introduce to every patient. Am I open to it? Could I see myself doing it if it was more accessible and easier in practice in the future? 100%. But currently, the ease of integration and those barriers and the way that I'm currently practicing, I take the 10,000 foot approach, and I think it's so, I love that you both study microbiome. I think of all the pathogens as like people at a party. And it's like the same thing, the problem that like a club has is like, how do we get the beautiful women? And then the people who are going to buy bottle service for the beautiful women is like, you set up an environment where like you can achieve that. So I'm like, well, how can I get,
Love it.
The things that I want is like create an environment that will draw that in and eliminate an environment that's not. And that's just a silly party analogy, the way that like I learned microbiome in my head. I want to hear about how you like, let's personify some microbiomes, like who's T for Sitha to you? Like, can we talk about this?
Yes.
Like what does P. gingivalis look like? What gender are they? Are they like...
I won't speak for Camille, but I think PG is the misunderstood bad bug. Right.
Definitely. Total emo in the corner, all crushed with spirit. Yeah. Mm-hmm.
Yeah. Fusonucleatum's probably the
social butterfly.
The glue. Yeah. just like on the dance floor, getting different groups to dance with each other.
Oh my God, we're such dorks.
FNUC, I promised somebody I would do a whole episode on that because I think we're demonizing that in a way that is harmful to the nitric oxide story. I think that, there are some FNUC that are bad, but holistically speaking, if it's coming up and you're not isolating which type of FNUC it is, it doesn't necessarily mean it's bad. And I think we could message better on that story. And so, yes, our social butterfly is getting a bad rap right now, mostly in the cancer space.
Like, do you think FNUC is a Gemini?
Ooh, yeah. Yeah. I could.
Like, are we going to give them sun signs while we're at it?
I like this.
I feel a book coming up.
Graphic novel. Someone needs to illustrate this 100%.
Yeah. I'm having thoughts already. There's this website called Primal Astrology that marries East and West. And they have a whole new character for that marriage. So your year and your.
Oh, wow.
So anyway, I'm a honey badger. I highly encourage everybody to look up their primal astrology. It's hilarious. My brother's an earthworm.
Oh.
Anyway, I could definitely do that for the oral microbiome, Jonathan. I think that would be a fun set of cards.
We've come a long way since Sokransky, guys. I mean, and I don't think we talk beyond that. Even as a Barrio resident, it kind of stops there.
It's true. I do feel like they Sokransky really set the stage for that discussion, but we've learned a lot since then, and we can use what we've learned from him as well as kind of the future forward. I know myself and somebody we had on recently who is working to basically. What you're saying is you're cultivating the location and trying to make it more appealing. Mm-hmm. And so that's about controlling the environment, the nutrients for the microbes, for example. Where is it coming from? It's coming from our food. It's coming from our host tissues. What are the things that are moving those needles as far as too much PG? I mean, we like a party, but we got to control the room, right? So, I think that there is a lot of opportunity in that space to use new tools that doesn't have to be invasive and really can be kind of what we call grass ingredients, generally recognized as safe, nutrient-driven elements to move the ecology or the environment to a space of health. I do think that, we're never going to get around this Western diet issue, but we can use these learnings and tools in new ways to help mitigate some of that damage.
Yeah. We got to meet people where they are, even if that's how they eat. We'll find a way. And creativity comes out of constraint.
And I think we're getting there. It's just making sure that it gets communicated, which is why we're here.
Yeah, definitely. This has been a lot of fun.
Yes.
This has been very engaging, very colorful conversation. I can't believe it's taken this long to talk about something as essential as dry mouth too. Even though I think our second or third episode ever was a spit episode. And it's probably our least popular.
Nobody wants to hear about it. It's so gross.
Yeah. which has been unfortunate for me because as we talked about, the role of quality saliva when it comes to nitric oxide, right? And the movement of micronutrients from your diet, its role of, managing our soft tissues in our mouth and everything else. It's
buffering, protecting, starting digestion,
right.
Intimacy, connection, speaking.
It's just that we have to retitle it to the KISS episode or something.
Yeah.
Yeah, we got to find something with a little more curb appeal.
Spit and star signs. I think we know what our next episode is.
Amazing.
Oh my goodness. Well, I hope we can have some time to talk about lasers and microbiome soon and regeneration. And I really enjoyed our time
Likewise. Yeah, the
together.
regenerative space is hot and heavy, so we have to get in there. Mm-hmm.
One way we like to end our conversations with our guests is asking, are there any books, shows, any media today that you're currently consuming or that might be an inspiration to you at the moment?
So I'm going to share some books. I'll share some books. This is on the edge of the healthcare space. One of my favorite books that I've read that's influenced how I practice is Competing Against Luck. And it is a sales focus, but what it really shifts is it shifts the focus to the consumer. And if you replace consumer with patient, it's all about shifting the focus to what the patient wants and needs and digging to the bottom of that. So if you digest Competing Against Luck and looking at it as a way to approach healthcare rather than in a way to approach our patients, rather than a way to approach like selling into a group, it was really an eye-opening read for me that kind of shifted how I practice a little bit. So it made a ding, and it changed a little bit of how I look at things. So
Very cool. I'm definitely checking that out. Are there any, you're a prolific speaker, so are there any conferences, speaking engagements that you're doing this year that we should all know about?
I would really, I'm going to drive the self-plug. I'm going to drive everyone. All my speaking engagements and lectures are up on my website at sarahbalaster.com. Become part of the movement. It's the DSB movement. We're here to disrupt, shift, and become. Disrupt the status quo, shift into a new paradigm, and become who we're meant to be. So DSB.
DSB, I love it. Sarah, thank you so much for volunteering some of your time to sit down and speak with us and to share and educate with our listeners. I'm definitely looking forward to having you back on the show so we can continue just learning more about you, for you to be able to educate us on lasers and also these other emerging technologies.
Well, thank you both so much. Have a wonderful day. Take care.
Let's get oral.